Okay, welcome to week 3. This week we're going to discuss some common respiratory problems that occur during infancy through adolescence. For example, we'll talk about asthma, cystic fibrosis, bronchiolitis, and croup syndromes. I will also discuss care of the child with a gastrourinary disorder such as UTI and pyelonephritis. And I will talk about some nursing management of children with these two conditions. Then I will talk about some nursing management of children with some common surgical conditions, and I'll discuss some common surgical conditions that you'll see in the clinical setting. Okay, so first in part 1, we will talk about asthma and then move on and talk about cystic fibrosis. Okay, so according to the National Heart, Lung, and Blood Institute, asthma is a chronic inflammatory disorder of the airways, which is a result of complex interactions between the inflammatory cells, mediators, and other airway tissue. So with asthma, it's the inflammation that plays a huge role in airway reactivity. And it's that inflammation that causes the bronchial hyperresponsiveness to a variety of stimuli. So that means that the airways will narrow too easily and too much to different stimuli. Also, the inflammation causes the recurrent wheezing, breathlessness, chest tightness, and coughing. So once again, it's the inflammation that contributes to the bronchial airway responsiveness. And it is the inflammation that leads to obstruction of airflow and the respiratory symptoms and the persistence of asthma. So then in asthma, the airflow obstruction is recurrent, so it can occur at any time, and it's the result of the changes that occur in the airways. Okay, so there are really 4 kinds of airflow obstruction. There's bronchoconstriction, airway edema, mucus plug formation, and the 4th is airway remodeling. With airway remodeling, there's structural changes that occur because of the repair process. So then the chronic inflammation then may cause the airway remodeling. And with airway remodeling, there is a permanent damage to the airways. And this damage cannot be prevented or it can't be treated. So here is an image of a normal airway. So a normal airway consists of the muscle that surrounds the airway, and then you have your mucous membrane, and then you have your mucus. Now, when a person has asthma, something will trigger an asthma attack or an asthma episode, and what happens is there are these mechanisms of obstruction there's muscle contraction, so the muscle constricts, there is inflammation that occurs, and there's edema that occurs, and then there's also increased mucus secretion. So you can see that the airway has gone from being wide open where the air can move out easily to a very small opening So where the air has difficulty, the airway is smaller, so less air is flowing through that airway. So you have expiratory wheezing. So the good thing about airflow obstruction is that it can be reversible with treatment, or it can reverse spontaneously if you take yourself away from whatever it is that's irritating it, triggering it. So asthma then, if it's not treated or it's unresolved, the end result is you're going to have impaired ventilation and gas exchange. You're going to have air trapping in the alveoli, and you're going to have air hunger. And then last, you'll have hyperinflation, which leads to hypoxia and acidosis. So you're going to have respiratory distress, which will lead to hypoxia and acidosis. So there are some precipitating factors. There are immunological factors or immunological stimuli, such as allergens. So there are outdoor allergens and there's indoor allergens, which can trigger an asthma attack. So outdoor allergens would be trees, shrubs, weeds, grasses, pollen, air pollution, and spores can trigger an asthma episode. Then there's indoor stimuli or allergens, such as dust or dust mites, mold, and cockroach droppings. All of these can precipitate an asthma episode if a person has allergies to these stimuli. Then there are irritants such as tobacco smoke, wood smoke, odors, strong odors, sprays, and exposure to occupational chemicals. All of these can precipitate or aggravate an asthma episode. Then there are some non-immunological factors, such as exercise. So some children have exercise-induced asthma. Cold weather, especially in the wintertime when it gets really cold and there's cold air, that can precipitate an asthma episode. So any changes in weather or temperature can also aggravate an asthma episode. Then we have some environmental factors. So for example, maybe moving to a new home or going to a new school, which I think is kind of closely related to emotions. New place, so it's stressful. Respiratory infections, or if a person gets a cold, that definitely can trigger an asthma episode. Animals like cats and dogs can also be a trigger. Now, there are dogs that are considered to be hypoallergenic dogs. These dogs have hair instead of fur, so they don't shed. So these types of dogs, hypoallergenic dogs, we would recommend for people if they really are insistent on having a dog. Examples of those would be a Labradoodle. There's quite a few terriers that they can have. There's Kesky terriers, there are Lakeland terriers, and there are Dandy Dinmont terriers, and there's a miniature Schnauzer, and also a Bichon Frise. These are all examples of dogs who have hair, so they don't shed, so they're really considered to be hypoallergenic. Other rodents and horses can also precipitate an asthma episode. Medications like aspirin, NSAIDs, and antibiotics and beta-2 blockers can also exacerbate an asthma episode. And then again, I talked about environmental factors like moving to a new home or going to a new school. I think that's closely related to emotions. So, like stress, strong emotions, like laughing or crying, can, if you'll notice somebody who has asthma, if they're laughing or crying, they might start coughing. Reflux can also aggravate an asthma episode. And then foods. So, for example, nuts, milk, dairy products, and maybe strawberries are foods that could trigger an episode. Additives can also be a trigger. Endocrine factors like menses or pregnancy or thyroid disease can also be precipitating factors. Now, signs and symptoms. It's important to remember that every individual doesn't have the same signs and symptoms. Some people might have shortness of breath, wheezing, and coughing, a paroxysmal coughing, which would be sudden non-productive cough. Or some just might have complaints of chest tightness and coughing. So, but common symptoms are shortness of breath, wheezing, coughing, which is paroxysmal and non-productive, and chest tightness. Those are common symptoms, signs and symptoms. Now, in order to diagnose if a child has asthma, usually they will have a chest x-ray. And the reason why you have a chest x-ray is that you want to rule out other conditions. You want to make sure that they don't have other things like pneumonia or other causes. And your H&P, your signs and symptoms, and if they have diffuse wheezing or a chronic cough in the absence of a respiratory infection, that will help to establish a diagnosis of asthma. Pulmonary function tests are often done. Pulmonary function tests are done to assess the functioning of a child's lung. Pulmonary function test is a valuable tool in diagnosing and monitoring conditions such as asthma. And in our picture, that's a child who's having a pulmonary function test. There's a little device that they'll be asked to blow in, to breathe in. They'll be given special instructions on what to do. It's a non-invasive and painless procedure. It takes 15 minutes to complete. And it's a computer-based device known as a spirometry that is used for the test. The test results then, when they're trended over time, can give valuable information about the health of a child's lungs and the improvement or the deterioration of a child's asthma. So usually they'll do pulmonary function testing to get a baseline. So the PFTs will measure respiratory volumes. All right, so peak expiratory flow rate, or PEFR, is a measure of the maximum flow of air forcefully exhaled in 1 second. So an important measurement is the PEFR. So the peak expiratory flow rate reflects the degree of airway obstruction in the large airways, and it can be used daily at home so a child can monitor their asthma. So here is a peak flow meter, and that peak flow meter measures a person's ability to forcefully exhale air out of their lung in 1 second. And if you'll notice, it's got the little red mark, so that's when they're in the red zone, and the yellow zone and the green zone. And we'll talk a little bit more about the peak expiratory flow value. So children with persistent to moderate asthma can monitor their peak expiratory flow rate to assess the severity of their exacerbation and the response to treatment. So then they need to first establish their personal best value when they're well. So over a 2 to 3 week period, they'll record their peak expiratory flow rate twice a day, and then they'll pick their best value or their highest value. And then at the end of their 2 to 3 week period, they'll see what their highest value was, and that is really their personal best value when they're well. So what they do with that value is that they'll the child's current peak expiratory flow rate can be compared with their personal best value at any given time. And this brings us to our asthma action plan. So with the asthma action plan in Children's Hospital, any child who comes in with asthma, when they go home, they are sent home. They should be sent home with this asthma action plan. So there are 3 zones of measurement that are used to interpret the peak expiratory flow rate. So there is the green zone, which is here. But if the child is in the green zone, that means they're 80 to 100% of their personal best value. And if they are in this green zone, then the asthma is under control. They have no symptoms, and they're supposed to just follow their normal routine, medication routine. And there'll be like instructions right here. Just, whatever their regular routine is, it'll be written down here. Then there's a yellow zone, and that is really the caution zone. So, and here on top it says they would continue with their green zone meds, and then they would add any. So the physician would add extra. So when they're in the yellow zone, there would be some instructions on what else they need to do, the additional medications. So if they're in the yellow zone, they are 50 to 79% of their personal best value. And their asthma is not well controlled. They're in acute exacerbation, and they should call their practitioner if they don't improve or if they stay in the yellow zone, because you want to get back up to the green zone. Then there's the red zone. The red zone is the danger zone or the medical alert, and that's where the child is 50% of their personal best value. That means that they have severe airway narrowing, and they need to take their short-acting bronchodilators need to be given if they haven't already done so. And they need to definitely notify the practitioner if their peak expiratory flow rate does not return to the yellow zone or the green zone, or they stay in the yellow zone, or they stay in the red zone. And most likely they will end up having to go to the emergency department if they're in the red zone, or if they're in the yellow zone and they're not going back up to the green zone. All right, so then the goals of management then is that you want the child to prevent any disability, and you want to minimize physical and psychological aspects of the disease. So you really want to encourage the child to live a normal life as possible. And you want the child to effectively be able to manage their asthma by being able to recognize acute episodes. You want them to be able to prevent their exacerbations and when to administer their quick relief medications. You also want them to be able to identify and eliminate any airborne allergens or irritants from their environment and avoid foods that may precipitate their asthma episode. So then children with moderate to severe to persistent asthma with a history of severe exacerbations really should learn to monitor their peak expiratory flow rate so they can assess their severity of their exacerbations and be able to treat them and manage them by using the asthma action plan. So then prevention is important. Um, so with prevention, you want to really make sure that children with persistent asthma should have a annual flu vaccine, and they really should stay away from people who are sick because any respiratory infection can trigger an asthma episode or aggravate their asthma. And you want to make sure that they take their prescribed medications. And the goal of medications is that you want to prevent and control their asthma symptoms, you want to reduce the severity and the frequency of their exacerbations, and you want to reduce the airflow obstruction. So because inflammation is an early and a persistent feature of asthma, the goal of therapy is to suppress that asthma. And that's really important. So usually before a child really starts to really have the symptoms, they're going to have that inflammation present. So you want to, it's really important that you prevent that inflammation. Okay, so now so asthma medications then prevent and control the symptoms and reduce the frequency and severity of exacerbations, and they reverse airflow obstruction. So there are two general classifications of medications. There's long-term control meds and quick relief medications, and they are often used together. There are long-term control meds which are taken on a regular basis to maintain or to prevent inflammation. And also, if you're preventing or maintain your inflammation, then you're preventing symptoms. Then there's quick relief or rescue meds, which treat symptoms and exacerbations. All right, so we'll start off by talking about long-term medications. Um, Again, the purpose of long-term medications are to reduce and control the inflammation, and they're considered to be preventative meds. These meds are taken on a regular basis to prevent the symptoms. So corticosteroids are anti-inflammatory meds, and they're used to treat reversible airflow obstruction. They're used to control the symptoms, and they reduce the bronchial hyperresponsiveness of the airways because it's really the inflammation that contributes to the hyperresponsiveness. So corticosteroids are used as first line meds in children older than 5 years of age. They are given orally, IV, or by inhalation. If they're given orally, the onset of action is 3 hours, and their peak effectiveness is 6 to 12 hours. They can have oral systemic steroids, may be given for short periods. So, for example, prednisone may be given in bursts. So they may be given for 3 to 10 days. And the purpose really is in order to gain quick control. Oral systemic steroids are also given for inadequately controlled persistent asthma, or they're given to manage severe persistent asthma, and they should always be given in the lowest but in the most effective dose. Okay, then we have inhaled corticosteroids. Example would be Qvar or beclomethasone, Pulmicort or budesonide, or Flovent or Asmacort. These are all inhaled corticosteroids. They can be given by inhalation. Then there's non-steroidal anti-inflammatory meds such as cromolyn. Now at Children's Hospital, they used to give cromolyn, but they really don't give it anymore. So I guess it depends on the hospital. Then there's oral corticosteroids. Examples would be dexamethasone, hydrocortisone, methylprednisone, or prednisone, or prednilazone. These meds also can be given IV when a child is in an acute stage of an asthma attack. Then we have bronchodilators, which are short-acting beta adrenergic agonists. These are used to treat acute exacerbations. So, and they're short-acting and they're quick relief meds. So they relax the bronchial smooth muscles and dilate the airways. So they relieve the wheezing, the coughing, and the shortness of breath. You have inhaled albuterol or terbutaline. Side effects are anxiety, rapid heart rate, headache, insomnia, nervousness. You'll see patients will have tremors or they're restless. Those are just common side effects if it's inhaled. Now, if you do meter dose inhaler, you have less side effects. And then we have long-acting bronchodilators, which are beta-2 agonists, are used in conjunction with low to medium dose inhaled corticosteroids. You have long-acting beta-2 agonists such as Ceravent, or you have combined medications which are beta-2 agonists and inhaled corticosteroid. An example would be Advair, which is in discus form, or Symbicort. Now, other medications which are long-term or adjunctive medications are given in addition to, usually they're used in conjunction with beta agonists and steroids, and they're given to provide long-term control by preventing the symptoms. And they're usually given with mild persistent asthma. They're not for acute episodes, so they're used on a regular basis. So these are examples would be leukotriene modifiers. What they do is they block the inflammatory and bronchospasm effects. An example would be for a 12-month-old and older children, Singulair tablets can be taken, and Accolate can be given for children who are 5 years and older. And these are leukotriene modifiers are usually children who have mild to persistent asthma, where they're not being well controlled on inhaled corticosteroids and bronchodilators, so they'll add the leukotriene modifier to their treatment. Then we have anticholinergics, which usually when a child is has acute asthma symptoms and they're in the hospital, they will usually get anticholinergics. It relieves acute bronchospasms, and it significantly improves lung function. And anticholinergics are used all in conjunction with albuterol. Examples of anticholinergic would be Atrovent or ipratropium and atropine. At Children's Hospital, if a child is in there for asthma, they'll be on albuterol, aerosol, in addition to Atrovent. And Atrovent is usually given every 6 hours, and albuterol can be given at every 4 hours, and PRN. Then you have monoclonal antibodies, and that's usually given for moderate to severe persistent allergic asthma. So somebody who has allergies and they have asthma as a result of those allergies. So the monoclonal antibodies then block the binding of the IgE to mast cells, and they inhibit inflammation. So many children who are atopic, and what that means is that they have a specific IgE antibodies to allergens that are responsible for inflammation, can be given Xolair, and it's used for patients with moderate to severe to persistent allergic asthma where symptoms are not controlled by inhaled corticosteroids. So Xolair has been approved for children 12 years and older, and what Xolair does, it blocks the binding of IgE mast cells to prevent inflammation associated with asthma. Now, the FDA has added the drug to the black box warning because it's been due to a reported immediate or delayed severe anaphylaxis. So it's in the black box warning. Children who present in the ED with moderate to severe asthma may who are not responding to albuterol may receive magnesium sulfate. That is given by IV. It's usually given in the emergency department, and what it is that it's a potent muscle relaxant, and it decreases inflammation. And then last, some children with severe asthma and a history of life-threatening episodes may need to have EpiPen on hand, and you need a prescription for that. All right, so now we're going to move on and we're going to talk about cystic fibrosis. Cystic fibrosis is an inherited autosomal recessive trait, so meaning that the defective gene is inherited from both parents. That gene is cystic fibrosis transmembrane conductance regulator gene, or the acronym would be CFTR gene. So the defective CFTR gene, then, there is a defective chloride ion transport across the exocrine and epithelial cells that cause a decreased chloride secretion and increased sodium absorption. And there's also a decrease in water flow across the cell membrane, which results in abnormal accumulation of viscous secretions and dehydrated mucus that affects primarily the respiratory, GI, and the reproductive systems. So these children, because of that defect is in the sweat glands, they're at risk for abnormal salt loss and dehydration. So then the what happens is that there is a mechanical obstruction that is caused by an increased viscosity of the mucus gland secretion. So instead of forming a thin, free-flowing secretion, the mucus glands produce a very thick and tenacious meconium that accumulates and dilates the exocrine glands. So all body organs with mucus ducts become obstructed and damaged, and they become fibrotic. So the primary symptoms are the result of the production of the thick secretions that obstruct the mucus ducts, and then eventually they become fibrotic and they become damaged. Then there's GI involvement, and that really varies among individuals. So so with GI involvement, the pancreatic ducts become obstructed and dilated, and they eventually become fibrotic. And when they're fibrotic, it prevents the essential pancreatic enzymes from reaching the duodenum to digest the fats and the proteins. And also, because of the impaired ability to absorb fat, there's also a deficiency of fat-soluble vitamins A, D, K, and E. And because there is impaired ability to absorb fats, most often these patients are very they're malnourished. Many children develop failure to thrive. And also, some children's pancreas may not produce sufficient insulin, so they develop diabetes mellitus. And they may require insulin. All right, then there's also liver involvement. There is biliary obstruction and fibrosis become more extensive over time, and it leads to multi-lobular biliary cirrhosis. Some individuals may develop fatty liver, and the gallbladder, the ducts are cystic. And as far as the reproductive system goes, for females, they have a normal reproductive structures. However, their fertility is affected because of that thick, viscous cervical secretions block the sperm. And as for males, sterility is common, mainly because the vas deferens is blocked with thick secretions, or the ducts fail to develop because they're blocked. And then last, the respiratory system is involved. So what happens is that the thick, tenacious bronchial secretions are present. So there's, and because they're so thick and tenacious, individuals have difficulty expectorating the mucus. So that mucus can become very stagnant. And the stagnant secretions are a medium for bacterial growth. So also, because of the thick and tenacious secretions, and there's a ventral obstruction of the bronchi and the bronchiole. So these individuals will end up with like scattered bronchiectasis, atelectasis, and hyperinflation. And again, because of this stagnant mucus in the airways, they're a medium for bacterial growth. So it eventually leads to bacterial colonization, and it really causes destruction to the lung cells. So some of the common pathogens are Pseudomonas aeruginosa, Burkholderia, Capsaicea, Haemophilus influenza, E. coli, and Klebsiella pneumoniae. Now, the Pseudomonas is extremely virulent in children with cystic fibrosis, and they quickly develop resistance to most antibiotics. So you really don't want CF patients to become colonized with Pseudomonas, because it's really difficult to get rid of that infection. So then last, as a result of the thick secretions, there is reduced oxygen carbon dioxide gas exchange. So they're going to have variable degrees of hypoxia, hypercapnia, and acidosis. So as the disease progresses, the end result is they're going to have chronic progressive fibrosis, and they'll, be in and out of the hospital for treatment, particularly for respiratory infections. All right, so there is airway clearance therapy, because remember the secretions are thick and tenacious, so they need to, clear their airways out. So There's airway clearance therapy, or ACT, helps to remove secretions and prevent pulmonary infections. So there is, as you can see here, this little device here. If you take care of a patient with cystic fibrosis, you'll see this at the bedside, and they should be encouraged to use it at least every 2 hours. So as the nurse, that's what you would do. You encourage them to do it every 2 hours. That PEP device is a positive expiratory therapy. You will instruct the patient to breathe out with moderate force, and what that does, it creates resistance and positive pressure in the airway, so it really keeps those alveoli open. So that's really important airway clearance therapy. Another airway clearance therapy is percussion and postural drainage. And in our little picture here, this is a portable one that's used at home. A vest will be put on the child. They'll turn the on switch, and it's high frequency chest compression. So you turn it on and it vibrates and it shakes and it loosens up the secretions. But in addition to that, the child will have bronchodilators to open up the bronchi to facilitate the expectoration of the secretions, and they'll also receive pulmozyme, which decreases the viscosity of the secretions, and that will help loosen those secretions. They'll may also receive nebulized hypertonic normal saline, and what that does, it improves mucus clearance. It improves airway hydration, but it can also cause bronchospasms. So oxygen may be needed at PRN. You have to really be careful with CF patients administering oxygen. So you have to have an order to know specifically how much oxygen they should have, because if you give them too much oxygen, it'll knock out their respiratory drive. And then they'll be on antibiotics. So you get a sputum culture, so you can get, start them on the correct antibiotics. And so now for the GI involvement or gastrointestinal involvement, children will have to take pancreatic enzymes with meals and all snacks, because it will assist with the digestion. Their diet should be a well-balanced diet. It should be high in protein. It should be high in calories, and they should have unrestricted fat because of their the impaired intestinal absorption of fat. So, however, when high-fat foods are eaten, they need to take some extra enzymes. They should also take multivitamins, including fat-soluble vitamins like A, D, K, and E. And then they should also, their immunization should be up to date, and they should always have their annual influenza, and I think they should also have their any other vaccines they should be up to date with. And that is the end of part 2. Part 1, excuse me, end of part 1.